lecture will be given by my dear friend, Professor Ashraf Armia from Cairo, Egypt. Hi, Ashraf. Thank you for accepting my invitation.
Hi, Rashid. My pleasure to join you.
Thank you, Ashraf. Professor Ashraf Armia is a cornea, refractive, and complex cataract expert from Cairo, Egypt. He is a fellow of the Royal College of Physicians and Surgeons of Glasgow and the American College of Surgeons in Ophthalmic Surgery. Professor Armia has impressive energy. During the last few months, he has given tens of high-quality online lectures and has also launched the GERSO, the Global Education and Research Society of Ophthalmology, which already counts 800 members worldwide. Professor Armia regularly gives lectures at the American Academy of Ophthalmology and has tens of teaching and training videos on YouTube and the International Society of Refractive Surgery website. Professor Armia will talk about the management of hard-work cataract. We know all how these cases are complex and difficult and might be very challenging. He will give us some useful tips and tricks to overcome these difficult and delicate situations. Professor Armia.
Thank you so much, Rashid, for this great two words. It's my pleasure and honor to be among you all in France to talk about the rock-hard progressing cataract, which is one of the challenging situations in ophthalmic surgery. It's my journey since I started since 1999 as a resident in ophthalmology, and till now I'm still working 2020. Next, please. I have no financial disclosure about my presentation on any material I'm going to talk about in this topic. Next, please. So, as we started the history of ophthalmology, we started from the intracapsular, which is sometimes we use it now, but I don't manage in my career now. I started from the extracapsular extraction till the PHECO for the pronounced rock hard cataract, then the PHECO for the intumescent hard cataract, then the new technology with the femtocataract cataract surgery in hard cataract, which can help a lot. Next, please. So in the video, can we watch the video, please? I'm going to put 4 cases in the video now, which describe the 4 types of these cataract. The first is the extracapsular. This is my technique. I usually do the corneal incision in a stepladder incision, the most perfect as much as I can from the cornea. Stepladder decreases the astigmatism post-operatively. Then I always do rhexis in the all my extracapsular cases, but instead of 6 millimeter, I'm doing in 6.5 millimeter continuous circular capsular rhexis that makes me easy to irrigate the cortex left after delivering of the nucleus safely and with no tags of the rhexis, which is the keystone in any cataract surgery. They don't leave any cortex behind. So after I did with the stain, I do a slight hydration. You know that in hard cataract we don't do hydroresection, but I do just hydration of the cortex a little bit slowly, then rotating till I deliver all the nucleus above the level of the capsular, which is easy now. But before you deliver the nucleus, you should inject a lot of viscodispersive to protect the cornea, because this is a very hard cataract. Delivering the nucleus in this way, rotation, with the cystotome is very hard cataract. Leaving the eye, you can do irrigation aspiration very easily, removing all the cortex, and you can implant safely 3 pieces, which is the PMMA lens, in the bag as you are doing a normal phaco case, but with this large wound. But to decrease the astigmatism, I always do my sutures in a radial manner. Each suture divide the cornea into 2 pieces, whatever the direction of the sutures. make the astigmatism regular, and you can remove the sutures easily post-operatively with the least astigmatism. Another case, which is the brown born-missing cataract with a good endothelial count, so I can do phaco in this case. The key step in hard cataract, a good size of the rexus, continuous, central. Don't do a small rexus in hard cataract. Make the division very difficult, and it can induce zone radiations very easily. The important step that you do grooving very deep, because these cases are very thick in the center. So as much as you can go deeply, I use my stop and shop technique. Division of the nucleus, you shop, you impel your phaco tip in one piece, and with the second, you can divide the nucleus into two pieces. Seeing the red reflex is a mandatory. If you didn't see the red reflex, you didn't divide the nucleus. Then each half, you are going to divide it by shop technique, which my preferable technique is the vertical shopping. You impel your phaco tip, and with the second near to the phaco tip, you cramp the nucleus. Usually I do 4 pieces. Each half I divide it into 4 pieces. After I finish the first half, I do the same for the second half. As much as you divide the nucleus, this is the less energy production, because all this phaco is inside the nucleus, away from the cornea endothelium. But to do a soft shell technique in these hard cataracts, it's very important to decrease the post-operative edema as much as you can, and to make the vision rehabilitation very quick for these patients. After you take 1/3 of these hard nucleus, don't forget to inject more viscodispersive to protect the cornea. Very important. As much as you put the viscodispersive in after each 1/3 of the cases, protecting, very important, decreasing the post-operative inflammation of the endothelial cells and decreasing the post-operative edema. Division of the nucleus into small pieces make you very easy. But my technique always, I don't use a lot of phaco in the quadrant removal. I do a very high vacuum, up to 350 or 450 in some cases. High flow rate up to 30 or 32. Make the nucleus come to your phaco tip. Don't go for them. Another case with the white milky cataract, which is I'm going to describe my technique, my preferable technique, which is the spiral rectus. Removing with the needle first, remove the fluid leakage. Then you start with a very small rectus, 3 millimeters, enlarge it into 4 millimeters, then 5 millimeters, and you are closing in a 6 millimeter, as Rashid always do for the ILML peeling, which is a technique for sure. So it is like this. It is the same way as you do like this. You are peeling, you do the rectus in white cataract. So also, as we said, division of the pieces is very important. Seeing the red reflex is very mandatory. If you didn't see the red reflex, you didn't crack. As much as you crack, as much you decreasing the energy to the cornea endothelium. After I do the multiple shopping for the pieces, during the quadrant, as you see, the pieces are coming to me because I'm increasing the flow rate up to 30 or 32, and the vacuum up to 450. And the phaco does not exceed 30, because I don't use energy in the quadrant removal at all, the least phaco power. Because we don't need in quadrant removal a lot of phaco. You need a vacuum and a flow rate. And you can divide mechanically the pieces with the second. So you are vacuuming the pieces. Phaco, we're going to make the pieces away. As you see, I didn't go out. This is a full operation. I didn't go out. This is my technique also. I don't go out. Every time I need anything, from the second side course. Also, with the femtocataract, in this very hard cataract, it helps a lot. I divide, I using the sectors with the catalyst, I don't have financial disclosure, and also dividing the nucleus into 6 pieces, which is, I think, more than enough, 6 pieces. And with the shop, you just impale your phaco-tip in the nucleus, separate it. Very easy. It's already separated, but you are helping to separate it more. You don't see it's very easy. The pieces are coming easy. And as much as you are in the center of the eye, you are away from the pupil and the iris. This is not a large pupil. This is about 5 millimeter iris. If you go with the phaco toward the pieces, you are going to catch the iris. And catching the iris in these cases, the beginning of the problem. So don't go for the pieces. Let the piece come to you by increasing the flow rate. This is a very important step in the hard cataract. And always protect your posterior capsule, because as much as the pieces, the cataract is very hard, there is a redundant in the posterior capsule. Thank you. Can next, please? So my tips in very hard cataract, a very good anesthesia is very mandatory. Don't go for topical anesthesia in this case. You don't know what the situation is going to be. A very well central, capsulorhexis, and central and continuous. Vertical shopping might prefer the technique, but you can use a horizontal shopping if you like this or you are used before. A very high vacuum with a less phaco power and high flow rate, decreasing the post-operative edema for these cases. Flex, the femtocataract is a useful criteria if you have it and the patient can afford. But always don't forget that extracapsular cataract extraction is very helpful in some cases with a low endothelial count and bad cornea, and the patient cannot afford to do PKP or DMAC for the patient. You can do a quiet, easy capsulorhexis and safe, and the patient will going to be happy. Thank you so much
for sharing with us these excellent cases. I really appreciate it. I am sure that our attendees will appreciate your presentation also.